The broadcast is now starting. All attendees are in listen-only mode.
Good morning. This is Deanna Mitchell with Leading Age Michigan again, and I want to welcome you this morning to our July 1st Safe and Calm webinar. We start the month of July with new guidance from the state, but very few real changes as the governor thinks about her response to rising numbers across the state, and those numbers have also spiked specifically in two areas, Lansing and Grand Rapids. So our agenda is basically the same. We will start with a very brief advocacy update. There's little movement now that the legislature is out, but there has been some updates in terms of the budget. We will review the caseload data, and then, of course, we will move to guidance and other resources. There are a lot of data slides this morning since CMS has published a review of the impact of COVID on Medicare beneficiaries. We won't spend a lot of time on these slides, but we wanted you to have them in case you were interested, or you could use them as background. Also, there's been two very detailed guidance issued by the state. The first is the updated guidance for visitation, which affects all residential facilities in Michigan, and the testing guidance, which at this point only impacts nursing homes. We have focused the nursing home only information toward the end of the webinar in case some of you non-nursing home members would like to jump off. So with that, I will turn the presentation over to Dalton Herbal, our Director for Advocacy, who will provide a brief update on state and national issues.
Good morning, everyone. Welcome to this morning's call, and thanks for joining us today. Today we're going to be going over a couple things that have happened. As Deanna said, the legislature is out on a summer work period. It being an election year, that largely means their work's going to involve campaigning and going door to door within their district. For today's call, we're going to be covering some budget framework that was laid out for the fiscal year 2020 budget. We're going to touch on what's going around 690, the PPP grant applications, and the CMP grant deadline being extended, as well as some national Republican legislator requests that were made to the Attorney General, just to give you some background knowledge on what's going on in Lansing. So Sunday night, early Monday morning, the governor and legislative leaders announced that a deal had been reached to backfill the budget shortfall for fiscal year 2020. This was largely negotiated in secret, and a majority of people didn't know these conversations were going on, and so much so that they created a one-page document to distribute internally to legislators to kind of fill them in on everything they know, and you'll see some of their tables on the next slides. And so what is in this package? The specifics, as I said, aren't known, but largely the framework shifts funds and uses the federal COVID dollars that the state has to backfill their budget. And they anticipate this largely taking place via executive order and legislation. So I would expect something to happen around the July 21st timeline, because that is when the legislature is going to be back in session for a day. So I'm guessing negotiations will happen between now and then something, you will see something on the 21st. So this framework largely kicks the can down the road of having to make those difficult decisions for fiscal year 2021, which is the budget that they'll have to be negotiating before September. It's going to make that budget extremely difficult because they're essentially spending all their one-time funds to backfill 2020. We feel that this is largely to get that behind them before they have to go into election mode, so they don't have to worry about the funding of this current year on the campaign trail. A couple things. We are looking to ensure that Medicaid rates and existing reimbursement methodologies aren't disrupted through this process. Nothing that we have right now says that they're going to be disrupted, but there's not a lot of information out right now. So we always have to remain vigilant. An interesting side effect of this is that now we are hearing bipartisan calls of from state legislators to the federal government to assist the state with the fiscal year 2021 budget. If you've been following the calls or any of the news in the past, you will have seen the governor making these calls explicitly because this was her plan. Republicans didn't want to join her in that message yet. But since they spent all these funds, now they're comfortable going to the federal government and saying, hey, can you help us for fiscal year 2021? We're still facing around $3 billion shortfall. So moving on. So this is one of those charts from their one-page document, and this details where the funds and savings are coming from. So a couple of interesting things to note. The school aid cuts and the community college cuts and the public safety cuts are the things being backfilled by those COVID dollars. So we have $350 million from the State Rainy Day Fund. That fund exists largely to deal with statewide traumatic things such as COVID or a flood. But right now they're going to use some of that fund to backfill some of the 2020 budget. There's also going to be $490 million in savings from state hiring freezes and spending freezes. And there's going to be $475 million dollars cut from the budget, which is now eligible to be funded by coronavirus. So the state's going to cut the budget and then spend one-time funds to fill in that hole that they create. And that's the same for the state aid restrictions to schools, universities, and local governments. An interesting thing to note is they're predicting $340 million for the continuation of the enhanced FMAP rates. This does assume that the state of emergency will last through December. And so the way this works is that the federal government has to declare when the state of emergency is over, or national crisis is over in their case. And that is when those funds will disappear. So the state is assuming that the national crisis of COVID-19 will formally last through December to get this $340 million. So this is a pie chart that identifies all the spending of the state's 3.1 COVID relief fund. And an interesting thing to note here is you will see the categories that are in the budget framework, but you'll also see the dollars that are in Senate Bill 690. So you can see in hazard pay for public health employees and public safety employees over there, $375 million. That is $375 million made up from the monies in Senate Bill 690 and the ones they had previously spent for in-home care workers. So this gives us a good picture on where everyone's head is at moving forward with 690. Everyone is assuming it's getting signed. My guess is that while they were calling it doing their financial diligence, they were actually talking about this budget framework and the go forward before she sat down to sign it. So we'll move on to our updates around 690. Since I think everyone thinks it's going to be signed, it still stands as is. It's still on the governor's desk. And a couple of minute advocacy points around it that were not minute, but a couple of advocacy points around it that we're trying to get done. We're trying to work with the department to make sure that the direct care worker payment increase is interpreted as a wage pass-through. And we're also trying to influence the application process for those PPE grants. In other states, providers have run into problems when the legislature has left it up to their state departments to make interpretations regarding who fits what category. And since our bill didn't really give us any sort of specifics in terms of how the direct care workers should be funded and the mechanism to do that, or the definitions for who qualifies for these PPE grants, we really are working hard with the department and we've heard from them that they're actually having these internal conversations right now. And so it's a good time to advocate on the behalf of these issues. Lastly, just to give you a kind of where the state of everything is at with COVID, as you know, the whole COVID response has somehow became some kind of political football game where the football's passed, handed off in all sorts of odd ways. You'll see this with various things at various levels of the crisis. But from a more macro perspective, the national Republican legislators have written letters to many state attorney generals asking them to investigate their state's COVID response plans. The interesting thing, though, is that this letter was only sent to states whose attorney generals and governors happen to be Democrats. So it's a little bit of political, but the interesting thing is the attorney general's response was largely pointing out that Michigan is not an outlier in terms of COVID-19. It's in line with many other states, Democrat or Republican. She did get a couple partisan jabs in there, which is always nice to see someone standing up for themselves. But she did focus on what she's done for Michigan, what has been happening around the politics of COVID-19 and how it's just kind of gotten out of control. And as once also I mentioned the CMS data showing Michigan's in line with other states. I've included a link to the letter if you're interested in this kind of thing for your enjoyment. So lastly, I posted on the listserv, I think Monday, that the CMP grant deadline was extended for electronic communication devices. This grant allows, for those of you who don't know, SNFs to get up to $3,000 to purchase one electronic communication device for every 7 to 10 residents. The deadline was initially, I want to say, June 30th, but it has been extended to August 1st for those facilities who have not had a chance to take advantage of it. A couple of notes to the department wanted to make sure we spread that you need to send the Excel spreadsheet that's included in the application, not a PDF of the spreadsheet. One application is required for nursing home. You need to include a contact person, include the NPI, and larger facilities may submit a request for more than $3,000 if it fully complies with the guidance. What a larger facility is currently not really well defined. We've asked the department to define what a larger facility is, and they are getting back to us. And then they also wanted to ensure us that you check your math before you send it. Otherwise, they have to send the application back to you. I put the email there for you to submit and a link to all the application documents in case you want to take advantage of this opportunity. I believe that'll bring us to questions.
All right. And obviously, before we get to the questions, Leading Age Michigan would just like to extend our sincere appreciation to our generous business partners who continue their support of our annual conference despite it being temporarily postponed. We look forward to your continued collaboration and remain grateful to all of you. So what does it mean to have a law interpreted as a wage pass-through?
It would mean that you would get, from my perspective at least, it would be that the funds are given to you to affect wages so that they don't have to be reimbursed at a later date, so they don't have to go through the cost reimbursement system.
Okay. And then someone just asked, are we going to cover the new MDHHS visitor guidance that came out? I'm assuming we will, but probably.
Yeah, Deanna has a slide or two in there later on.
Okay. And then someone just said the funds are not subject to the VCL limitations.
Yeah.
All right.
That's for the direct wage pass.
Okay.
By the way, for the areas.
All right, are the only questions I have for this section, so it looks like we can move forward. Thank you very much, Dalton. Deanna, are you ready?
Oh, yes, I'm ready. And
All right.
I have a lot of slides, unfortunately, on the visitation guidance. But we're going to start very quickly with a situation update. As I said before, I do have a lot of slides here, but I don't want to spend a lot of time on them. There's a lot of Medicare data that's just come out. And one of the things, of course, that we've noted is that the trends are continuing upward. So our first few slides are taken from Johns Hopkins, and this first is the number of daily cases per million across several countries. It was published on 6/30, but the data, because it's there's a lag period, is current to 6/28. Note that there are increases across many countries, but there is a definite upward trend at the top of the number chart for the US, unfortunately, which is in red. The next slide includes the deaths per million for the same time frame. Note that the numbers are a bit more stable, but also very slightly increasing as well. Here, again, this is a Johns Hopkins slide. We have the number of active cases. These calculations only start when a country's caseload hits 10,000. So for the US, we are hovering around day 70 since that time. And note that we had a small dip about a week or so, but now, again, we are climbing. This map I thought was interesting. It's from the Kaiser Family Foundation. It's built on Johns Hopkins data, though. And it includes the number of states, which unfortunately is 26, with upward 14-day trends in the number of cases. A lot of these states are heavy population centers, but many are also not. And of course, unfortunately, Michigan is included here. These next several slides are taken directly from the COVID-19 Medicare data snapshot, and it was issued just a couple days ago. Again, we won't go into them deeply, but it seems like we have some really interesting information here. This first one looks at total Medicare COVID cases, meaning cumulative cases per 100,000 persons. Note that the East Coast still holds the highest numbers: New York, New Jersey, Connecticut, Massachusetts. However, Michigan still kind of stands out there as one of the states with the highest proportion of Medicare beneficiaries who've been affected. So remember that these next slides only have to do with Medicare beneficiaries. This data includes the number of Medicare beneficiaries with a COVID diagnosis from January through mid-May. The purple line toward the left is the norm for respiratory infections across winter months. While cases seem to peak around May 2nd, it might be a little bit misleading because there could be a claims lag as recent as early May. So these are the cases, the Medicare cases that we're talking with COVID diagnoses. They did change the diagnosis code, so that's the difference between the light blue and the dark blue. Here we have the number of cases per thousand by Medicare group. We've long known that the 85 and over category is at high risk, but there are also a large number of cases among end-stage renal patients and persons who are duly eligible for both Medicare and Medicaid. We know that group tends to be a more frail population. So for Medicare beneficiaries who are hospitalized, CMS notes that about 28% died and about an equal number were discharged home, 27%. About 1/5 were sent to skilled nursing facilities and only 2% were sent to assisted living level care settings. About half of all the Medicare beneficiaries, though, only had hospital stays of less than 7 days. This data is from the CDC National Forecast, and what they do is they look at a huge number of forecasting algorithms, and you can see them listed on the left, and you can see all of the colored bars there on the right of that graphic, which shows their projections, and their projections vary quite a bit. The red line on the right, on the graph on the right, shows the median projections through July 15th. And so you can see that if you take an average, or a median really, of all of those algorithms, they're still projecting an upward trend. This slide shows the same projections for a number of states, and I included the page with all the M's on them in Michigan. While all these trajectories have a kind of similar curve, you can see that Michigan rose a bit earlier and leveled off fairly well. And the median projection on the right is a little flatter than some other states, so that's kind of good. But remember that this data is based on recent past performance, and it could change if our increases keep going up. Our last few slides here are the ones that we do pretty much every week, the standard Michigan cases. And of course, the caseload, even as of yesterday, is still continuing to rise. Remember, this is a 7-day rolling average too, which, you know, kind of levels out the spikes. And until yesterday, the deaths continued to be declining, probably due to the fact that a lot of the new cases are younger and healthier persons. But yesterday, there was a large spike in the number of deaths, and in fact, large enough that the 7-day average took a jump upward, and you can see that at the far right side of the graph. And interestingly enough, this is the most recent data on the nursing home caseload. We started tracking this last week because we thought the data was finally accurate. However, note that after reviewing the data, the state decided that they validate some of the data, and that the numbers have gone down as of 6/29, which is good if it's accurate. However, we're still not sure how accurate these numbers are, but we will continue to monitor. Blake, you can move. Yeah, okay. So
I'm sorry, it wasn't.
That's okay. So cases are rising, and that plus the state's feeling that they have to have testing outcomes to figure out how to proceed going forward. That's going to impact senior care moving forward. So that's kind of the framework that we have to use to figure out what's in front of us. We'll move on to resources updates, and then we'll talk specifically about visitation and testing, both of which are kind of related. So general resources. There were several articles put out in the last week. I thought that they might be of interest to everyone. I don't want to spend a whole lot of time on them. We will put the links to these articles. The first is from JAMA. It talks about the need for some of these scientific organizations to rethink about their mathematical models, because they don't really include the different kind of experience that occurs in residential care settings. So if you have an area with a lot of nursing homes, you should be looking at projections for that area differently. The second article is about patient safety. There is a huge message here about ensuring that you're not pulling your quality staff off to assist with resident care, that the only way to really ensure that you're going to be able to perform during the pandemic over time is to keep that staff dedicated to quality issues on an ongoing and very daily basis. And there's a lot more in that article as well. Testing. Michigan recently put out a new test finder that allows you to put filters in. These filters say things like you want testing sites that will take someone without a doctor's order, or you want a testing site that is open certain times of the day. Anyway, there's all these filters now that you can apply. And the link, of course, for that will be in the Q&A as well. Another note that in the past week, HHS renewed the public health emergency. That is really important because that is the framework upon which we are allowed to get an extra FMAP rate for our Medicaid program, and other things like our waivers, our blanket waivers, are also dependent on that public health emergency. The last, excuse me, the last article, which the link is at the bottom, has to do with psychological safety issues in facilities. It has some tools to help you evaluate and look at that. Okay, so now we're going to move on to the visitation guidance that was just issued yesterday. First of all, the state has been issuing guidance through systems that we're not quite used to. They have been issuing guidance through MyHand, so if you're not used to getting things through MyHand, please make sure that you're registered in that program and that you're monitoring it for updates. They're probably using MyHand a lot more because a lot of these initiatives are related to the pandemic itself, and that's an emergency response system. And the other thing is that I first got this directive yesterday through the Michigan State Police alerts, believe it or not, before I got it anywhere else. And that's another good thing to be registered and signed up for. And it can really, they give you the most recent and quick updates on what's going on anywhere related to the pandemic. So there's a couple things about this guidance that we need to note. It really doesn't change the underlying requirements much. We heard from the department late last week that they were very reluctant to move beyond current restrictions because of the increase in caseload and the fact that they didn't believe that enough of the testing program had been initiated yet. So, and as much as we talked about the need to look at independent living a bit differently, it is still there as well. And after some of our discussions, that wasn't a huge surprise, since during one of the discussions, Dr. Caldoun clearly expressed as much concern about the risk for independent living as she did nursing homes. So the types of facilities covered here are not changed, and we listed them on the right. And the type of visitation really has not changed either. But we'll go into some of the new details that they put around and clarified what that means. So what they've done is put some new details out about what those allowable visits look like. There are really only two categories discussed here. The first is when family, friends, or visitors can have a positive impact on resident well-being by assisting with certain ADLs. They use the example of refusing to eat and having a family member or a friend helping to feed. And the other allowable visit is when a resident is in serious condition or in hospice care. Visitors who meet those criteria must wear a mask at all times. They must use appropriate procedures and the standard safeguards during care. Such visits must be scheduled in advance, and they must be isolated in a private room or a designated room of some sort. And then, of course, they applied all of these additional rules. They want these visitations to be by appointment only. They strongly suggest that you have logs that identify when people come in and when out. I think most facilities do that anyway. They want to expect a limited number, no more than 2 at a time, and for limited time periods as well. Each visitor must use a mask, must demonstrate appropriate hygiene practices, hand washing, etc. They should come through designated entrances only. Just because they're allowed in the building does not mean they can ramble all over. They must be screened like everyone else. They should have access to testing as well. The facility must have access to testing requirements when you're having these kinds of visitors come in, and we all know that we're all testing anyway. Facilities are supposed to post information that all visitors must be screened, what the symptoms are to look for, etc. They have to provide visitors good hand washing facilities and hand sanitizer. Facilities must have adequate staff to assist with, the guidance said transition, but I think they really mean transporting as well here. Monitoring during such visits to make sure that safeguards are being adhered to, and a process for disinfection if you're using any kind of area, especially that is outside of the resident room, but disinfecting the resident room as well after these visits. Visitors are expected to report symptoms, any symptoms developed within 14 days of their visit. Even though they're technically not allowing just blanket outdoor visitation, they do expect that you use the outdoors for these sorts of visits if feasible, with the idea that you now have to have staff to transport persons in and out of the building. There shouldn't be transport or any kind of movement of visitors or non-COVID people through a COVID dedicated space. The visitors should be educated on PPE, and if additional PPE is needed because of some risk, they should be provided that. They should not be around during aerosol generating procedures or specimen collection at all. Again, restrict visitor movement through the facility. They must be socially distanced from everyone. The only exception to that is if they're feeding a resident or something. Obviously, they can't be 6 feet away. There should be a staff person available who is trained in infection control during any time visitors are present. That might be a little bit of a challenge. I'm not sure exactly what that means, but that is a statement in the guidance. You need to limit the number of visits based on your space and your infection control capacity. They should be admonished not to share food, residents and visitors together. And of course, all visits are prohibited for positive COVID patients or patients who are under observation for symptoms. So the other category is visitation to residents in serious condition or in hospice, and there's a bit more explanation than we had before here as well. Being enrolled in hospice alone is enough to warrant a visit. You don't really need to be judged to be very close to end of life. Anyone whose well-being is at risk because of loss of visitation can fall into this category as well. The state is requiring, though, that be a medical judgment, and we assume that some documentation about that would be warranted here. And visits also must be considered an appropriate intervention to whatever the clinical issues are about specific residents. Anyone who experiences a significant downward change in condition can be included here as well. And again, though, that would have to be with medical judgment. So that's the visitation guidance. It gives you a little bit more leeway, but to be honest with you, not much. And we're hoping that as the state gets more testing and we look at community transmission, they might be willing to open up visitation a little bit more in the future. Executive orders. These are this first slide. I think I have 2 slides on executive orders. These are the orders issued since our last review. Only one in this list really applies to us, and that is EO 135, where the governor created a task force for nursing home COVID preparedness. And David Herbal from Leading Age Michigan has been asked to sit on that committee. The only other executive order published since our last webinar is 2020-136. And of course, that was the renewal of Executive Order 108 that includes the visitation and health screening requirements for all residential settings. I think the governor's put out a couple more EOs since I did this slide, but they do not impact long-term care or senior care. CDC updates. There must have been 50 CDC updates over the past 5 days or so. Luckily, most of the changes were really small or not even applicable to senior settings. This first piece, though, is about preventing spread in independent living settings. And one of the interesting things here is that they label different characteristics of the facilities in terms of risk. Not risk by type of facility, but risk related to the layout and the behaviors of the resident and the facility. So an independent living is considered high risk for transmission if residents are socializing together either privately or in common areas, if residents have frequent off-campus visits, and if non-essential volunteers and visitors are not restricted. So it might behoove some of our members to look at this entire guidance. It's rather interesting. On the next slide, the recommendations for these retirement communities and independent living are listed, and none of them would really surprise us, but they mostly focus on, again, social distancing, routine precautions, more frequent cleaning, and definitely closing the common areas. The CDC also issued a guidance for the same group, retirement and independent living settings, that focus overall on safe operations during the pandemic. And there are several links from that original guidance. The major web page for that is at the bottom, and then they have several different other operational ideas and facts for administrators, FAQs for administrators as well, that seems pretty interesting, and they go into a little bit more detail about how to provide enough safeguards for residents. So the CDC also, in the last couple of days, updated its recommendations to state and local health departments for the need for broad-based and what we would call serial testing for all congregate settings. What we thought might be helpful here is that they include recommendations about setting up testing and testing space, along with protocols for doing that. There's a lot of detail in this guidance that might help some of our facilities who are doing testing. Over the past weekend, the CDC also updated these guidances, though in the review, I couldn't really see where the changes were, at least on first look. They continue to identify contingency strategies for optimizing the use of all these different kinds of PPE, but we will continue to review these because they'll continue to be important going forward. It looks like we're going to have PPE needs long into the future. Yesterday, the state put out a notice to My Choice agents about ongoing provider monitoring during the pandemic. So assisted living, AFCs, HFAs that might be coordinating care for residents under My Choice should note that provider monitoring visits may be delayed, excuse me, or they may be made virtual depending on each situation. So you might be hearing from waiver agents if you've been working with them. They do, however, have to get departmental approval before altering any monitoring calendar out there. So we're going to pause here now and take questions about any general updates. Please hold any questions about nursing home specific guidance for a bit. We're going to go over that after this question period.
All right. And then each year, Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we'd like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank these business partners by supporting their programs when you are in need of their services. Here's just half of the list of people who will be joining us for our Solutions Expo once we get that back up and running. So I do have a decent amount of questions here, so we will just start powering through them. So visitor guidance says, persons trained in IC present at all times during visit. Does this mean physically present in the space of the visit, in room or in outside tent, or just on-site working in the area where visits occur? Having someone present during each visit would essentially be providing a 1-to-1 staffing ratio. We could have an outside scheduled visit and a couple end-of-life visits occurring, needing 3 extra staff to be present for them. Deanna?
Whoops, sorry, I put myself on mute for a second.
Oh, okay.
My apologies. We took this to mean that you need to have an infection control person on campus whenever you're having scheduled visits, not to at all make sure that that person is associated directly during that visit with the resident and the visitor, but as someone who could be referred to if there are issues about safeguards and compliance.
Okay. And then I had a couple questions regarding getting the link to register for the Michigan Hand or MI Hand program that was referenced.
I can try to provide that through the Q&A.
All right, sounds good. So that will be sent out. So that takes care of like 3. Do we know what is meant when it says the facility must have access to testing? Does this mean that access to testing is on site?
No, it just means that you need to have, you need to be set up to do testing should something occur, such as a positive case. It does say that in the guidance. However, every nursing home in Michigan right now has to test, so I think that's really moot.
All right. Families, visitors can't do many ADLs, give baths, etc., and sniff AL, so this doesn't seem helpful. And if they are needed to help someone eat, we need to provide training, correct?
It is correct that you need to provide training. You should also observe and document their ability to do that. And I agree 100% that this does not provide a lot of flexibility in terms of visitation. And to be honest with you, the state didn't mean it to. They do understand that a lot of residents are negatively impacted by the isolation and lack of visitation. So they're trying to create some avenues for those persons who are really having difficulties with it. However, they are very, very concerned about the caseload in nursing homes and in community transmission right now. They are fearful that we're going to continue to rise, and therefore they're very reluctant to do much more than they've done so far.
All right. Do you think they will carve out IL soon? What can we as members do to get IL removed from this? They are not monitored or licensed, and we don't have staff monitoring them. If someone has an IL apartment not under a CCRC roof, standalone on a campus, how do we tell them they can't have someone come to their home?
We understand that. And in fact, we've said that, these persons consider themselves completely independent and do not see themselves under the purview of a facility like a nursing home would be. We have had that discussion many times. However, epidemiologists and especially Dr. Caldoun at the state is very concerned because these are close settings for seniors, and they really have not relaxed because of that. We have presented this to almost everybody at the state that we possibly can. They're not budging at all. I would suggest, continued advocacy to legislators and the state. If you want to write some letters to Dr. Gordon, I think that would be an excellent idea. We have, again and again, discussed this issue, but have gotten nowhere right now. But what we have heard and seen is a real reluctance on the part of a fear. Let's just call it a fear on the part of the state that COVID is going to come back, and is coming back very soon. They're worrying about overloading the hospitals again, and they see trouble down the road. So it isn't so much that they don't understand the dilemma with independent living, but they just are fearful of COVID overall. And there are a lot of vulnerable seniors who are living in those spaces. But continued advocacy, we can talk about that moving forward as we have. I don't know where it's going to get us until the caseload goes down, though, and the testing is done and showing improved numbers.
All right. Can you clarify on dining? Executive order says no communal dining, but I hear about some places doing dining social distance in groups less than 10, some less than 50 in their AL, IL, and SNF. Is this allowed?
Technically, I believe I would have to go back to the AL and HFA, AFC, rather, FAQs, which pretty much, I believe, still say that communal dining is not allowed. The CMS guidance for communal dining for nursing homes is a little bit more relaxed, and it allows things like one person at a table, obviously no movement between person to person by staff to do feeding or anything. And as long as you can socially distance and make sure that people who have symptoms or are COVID positive, of course, are not in the dining room. And this has been a dilemma through the time because it still looks like for AL and HFAs and AFCs, the FAQs say no communal dining, but the CMS requirements are a little bit looser. I'll go back and look at the FAQs to make sure it still says that. We have brought this up to the state before. They were looking at it, but I don't think that they've budged. So basically, you have some inconsistencies here. I think that there is some support, perhaps, for doing a very, very a methodology that's close to the CMS guidance. But we will try to confirm with Laura what their take is on HFAs and AFCs at this point, again, as well.
Is there any new information on outdoor visits for those who do not meet the 2 criteria in 333.2253?
Yes, when directly asked, the state said no outdoor visits as of late last week. Actually, it was Friday afternoon after our webinar on Friday morning. We had a call with the state, and they said they just are too fearful at this point.
All right. Do you have any recommendations for hairdressers if a resident can't go out to get their hair done?
Technically, they are not essential. Technically, they are considered, they would be considered, I think, a visitor. They're not someone who's essential to care. So technically, they're still not allowed. What do we think about that? I don't know. I think it would be better probably to have someone to come into a facility rather than to have residents go out for hairstyling. But right now, the guidance says no.
How does the testing portion apply to HFAs? It's my understanding that HFAs aren't currently included in the weekly testing that SNFs are doing.
That's true. We've not heard anything about testing in HFAs. For some reason, they seem to be more worried about cases in nursing homes. There is a lot more movement in nursing homes and admissions from the hospital, et cetera. I've not heard anything about that. We've not discussed it at all, actually. Just reporting. HFAs and AFCs are required to report, but not to test at this point.
That point on testing is not moot for IL, and that is included in this order. I'm not sure what that pertains to. I'll just hold that one for
I will look at that question later. Testing is not required for any senior congregate setting except for nursing home right now.
All right. Encouragement is also assistance with ADLs, right?
I would think so. In order to meet the details of the guidance, I would think that you'd have to identify exactly what you were expecting to achieve. But yes, I think encouragement to eat, encouragement to walk, encouragement to do any of the things that would enhance someone's well-being. The thing is that technically you have to demonstrate that the person is losing function and having difficulties because of the isolation. And in some cases, you're going to have a physician or an extender agree with you and be consulted for that.
Okay. Since well-being visits can be done as deemed needed by physician, do you think that being isolated 4 months qualifies as needed for their well-being? I see this being a way to get at least one outside visit for everyone.
I think that would be a very helpful way to look at it. I'm not sure that's what the state intended. I would think that they would expect that the person would display some loss of well-being, that generically just because we know it's good for people would not be enough. However, I do have to say this. I don't know that the state's going to monitor this very closely. This has not come under the purview of Laura. So I think that you should take the guidance and make it work for you, but remembering that there are risks associated with increased visitation that you have to be very careful of. And technically the guidance only does include people who have ADL needs that need to be addressed and some sort of specific well-being needs that need to be addressed.
All right. Moving through the phases is still part of the plan for reopening, correct? So if we have about a quarter of residents who refuse to be tested, does this impair your ability to open up for visits? I thought I read 28 days without COVID in our community would be one of the stipulations.
Well, that is the CMS guidance. And I think that right now, the state is working not on a facility-based guidance or methodology, but a regional based and maybe eventually a county based methodology where they're going to look at community transmission and other things. So how they actually reopen this is kind of up in the air. I don't know if they're necessarily going to look at your facility. However, if there's a lot of nursing home residents in an area with COVID, they're probably not going to reopen. We don't know exactly how they're going to look at that, but that is the CMS guidance and not the state guidance. And in this area, the state guidance is what is going to reign here.
Okay. Not sure why the state had a task force and then completely ignored their advice. I guess that is just a comment. I think EO 2020-123 says no communal dining. Does this overrule the CMS guidance?
I would have thought so at one point. However, I do think that I have seen some information from the state that, or maybe it was during a conference call, where they alluded to the CMS guidance as okay. But then again, they were only talking about nursing homes and not necessarily, it was a call with MDHHS, not Laura. So I do think that the state does anticipate that the communal dining flexibilities from CMS are okay. Again, though, I think we should check again with Laura. The last time that we talked, Laura kind of was stuck on no communal dining for AFCs and HFAs, which I think is problematic, but we can only keep trying.
All right. So AL cannot allow communal dining?
Technically, I believe that's correct at this point.
All right. Am I clear that nursing homes with no positives on baseline testing and low incidence regions does not need weekly staff testing, correct?
If you're in region 6 or 8 and you have no current cases, you do not need weekly testing.
All right. Letter E. So someone says in letter E in 333.2253 says has adequate access to testing for COVID-19. IL may not have this.
That's true. Let me go back and look at that in terms of context, and I'll respond to that in the Q&A.
All right. What about family instruct for rehab patients? Can the family come in for that?
Family to do what for rehab patients?
It just says family, I'm guessing family, and it just says family instruct, but I'm assuming instructions or something along those lines.
If you're trying to get encouragement from the family during rehab, I would think that that would be outside of the guidance unless you have some sort of documentation that says that this person's well-being is being impacted by lack of visitation. Again, that's, a strict interpretation of the guidance.
All right. Is there anything in writing about no outdoor visits as previously mentioned?
Well, the guidance says no outdoor visit. Well, no, I would say no. There's no specifics about outdoor guidance that I'm aware of off the top of my head, except that guidance does say that visitation is limited to those 2 categories, and that's the only place where they're allowing outside visitation. So I would say, in terms of relations with that, there is no outside visitation, but it is not specifically said that way in any guidance that I'm aware of.
All right. I have heard of a facility being cited for having outdoor visits.
You have? Is that what they said they have?
Yes, somebody had said that. So maybe if you can give us a little bit more information on that, or maybe let us know what community, that would be nice. What about communal dining for IL? Also still none, since IL is considered under the definition of residential facilities under the EO.
Can you repeat that, Blake?
No,
my brain isn't wrapping
you're fine.
itself around it.
So it says, what about communal dining for ILs? Also none, or also still none, since IL is considered under the definition of residential facilities under the EO?
Yes, communal dining is currently not allowed in any congregate residential setting, including independent living. And in fact, if you go back to the CDC guidance that I was referencing earlier in the webinar, you will find that the CDC recommends no communal dining, or actually any common area grouping in independent living or any senior residential settings at all as well. That would put the facility at a very high risk for transmission.
All right, IL residents can leave and do what they want. So what if they go outside and sit with people who happen to be on our campus? We are not scheduling visits, but they are doing this on their own.
Well, if you're saying if they're going outside the facility campus itself, you're right. They can do whatever they choose to do. They're independent, free people. You do have to screen them coming back in. That is still a requirement based on the executive orders. If you screen them in terms of their activity and contacts, you can make a decision about making some recommendations. You should have policies in place about that. It's not clear how much you can regulate what independent living seniors can and cannot do. But I think that the focus of the CDC and the state is on educating everyone as to the risk and including them in the discussion about what risk they might be bringing to the community. But you're still supposed to be providing safeguards, frequent cleaning, recommending social distancing, mask wearing outside of apartments, etc. Independent living facilities are all expected to be fostering that sort of behavior.
All right. The person just said that is the challenge. We don't have staff 24/7 in those areas to monitor and screen them.
Right. Well, and we do understand that. So I would assume do the best you can. And we have made all of those arguments to the state already.
All right. And then Dave says, in a discussion with Director Horvath, there has been no referrals to his agency. Not sure how someone has been cited for outdoor visits. Only MDHHS has authority over visitation, and we have not heard of them or the LTC ombudsman being out in the field.
And we can look into that. I do think that there is some CMS guidance about visitation right now. Although they have deferred it to the state, it might have been before they deferred it to the state. I'm not sure. We can look.
All right. It looks like that takes care of the questions for this section, so we can move on.
Okay, and we are running a little bit late on time. We're going to move forward with the nursing home guidance and updates. And I will try and do that as quickly as we can because a lot of this is not new. So I will focus on only those pieces that are new. The first update, if you move to the next slide, is about F884 citations. This has to do with facilities who were cited because of reporting issues for data that's supposed to go to NHSN. So if you've been cited by CMS through a 2567 and you think wrongly because there have been reporting issues, you must dispute that directly to CMS as well, not to the state. So the notice that comes with the 2567 includes all of the information that you need to appeal. It is listed on this slide. It also has an email address that you can send it to. And if you have questions about this, I ask that you contact Laura Funch or any of us through our Safe and Calm email address, and we will try to assist you with it. So now moving on to testing. The department issued 7 new or updated documents on COVID testing last Thursday through MyHand. We will review these with a focus on just the changes and updates. There's a large number of new questions in the FAQs, but a lot of these documents that they reissued have been unchanged. So one of the documents that they sent was the epidemic order based on Executive Order 136, which notes the department's decision to not reopen visitation before there is really robust testing of residents and staff. So there are no changes here from before. Plans must be in place by June 22nd for testing and initiated by 6/29. Those still hold, although there has been an extension to the date required for completion. So there's nothing new here, and all of this still applies. The testing guidance itself was also reissued, and there were no new updates here either. Although there were some later clarifications in the QA about testing persons who were previously known to be positive, and we'll talk about that when we get to the new QA. But basically, the testing guidance that was issued on 6/15 was reissued last Thursday, and it has no changes in it either. The documents did include testing resources for those facility-conducted testing. In other words, for persons who are newly admitted and haven't been tested in 72 hours, or persons who develop symptoms and need to be tested, the facility is meant to conduct those tests on its own using laboratories that the department has developed a list for, and that list is at this link. The state says that these labs should be supplying your specimen collection materials to you for that. For weekly testing, though, they do suggest that facilities should conduct it if they can, but there is state assistance available for that. For PPE needs in general or related to testing, facilities are asked to contact the Regional Healthcare Coalition. So now we come to the FAQs, and we have them detailed out here because this was an updated document, but there are so many new additions. The updates and changes to the FAQs are highlighted in blue for the next several slides. So we're going to focus on those. The first part of the FAQs are about residents who refuse testing but may be symptomatic. They have to be isolated outside of the dedicated unit. There must be medical consultations to determine the appropriate steps for residents who refuse, but they note it is never appropriate to restrain a resident in order to test. That is a new piece that is in the FAQ. Other changes in the FAQ include the date to request assistance from the state. You'll notice that's there in bold. It was originally 6/22, but it's now extended to July 6th, mostly because the department issued the wrong email address for the request. Facilities have to complete the template that was included with these documents, and remember that the last data test to meet Region 1 to 5 requirement is still technically July 3rd. They still want you to have that testing by July 3rd, but they're not going to enforce if the facilities come into compliance by July 17th. Again, those same dates are reiterated in this section. Also note that the department will not hold you to an every 7-day cycle, but facilities must ensure that all are tested within each 7-day period from Sunday through Saturday. Although this is not new in this update, we wanted to remind everyone that the state revised the plan for retesting positive persons, and that's at the top part of this narrative on this slide. Retesting is not required for about 8 weeks. It could be 6 weeks, depending on whether you're using a symptom-based or test-based strategy. But beyond 8 weeks, these persons should be tested if there's weekly testing along with everyone else. From this point on, I think all of the FAQs are new. Weekly testing of residents and staff is required for 14 days beyond the time of onset of any new facility acquired case. If you're looking at baseline testing, if some of the residents were tested earlier but not all, facilities can go ahead and retest the other residents only and call that done in terms of baseline or initial testing. The updated guidance includes a definition for resident contact, what that means. And the state is also working on rapid response staffing resources that can potentially provide up to 72 hours of assistance if there are a lot of staff testing positive in any one facility. But right now, that will only be available in West Michigan and Southeast Michigan. For vacations, facilities are suggested to screen on return, and as long as they're asymptomatic, and this is for staff vacations obviously, test as soon as practicable, but they can work until the results are in. Unless they have identified possible exposures in the screening process, each facility should develop some rules about this in their policies. Accommodations must be made in your plan for staff who decline testing for medical, disability, or religious reasons, and there is a link there to the EEOC guidance about that sort of thing. New staff, however, must have negative results before any direct resident contact. And persons with positive antibody testing are still subject to weekly testing with all the other staff. I don't think there's anything really wild in this group of the new FAQs, except for maybe that any nurse can order a test. That's one thing that there's a waiver for under one of the executive orders. You do not have to have a physician order the test. Funeral home staff who enter buildings do not have to be tested, but they are recommended based on the frequency of their visits. This is the last document that I think we're going to review, and this is one that a lot of members have been waiting for on how to fund testing. The state intends to cover all costs not covered already by insurance, but requests for state assistance have to be in by July 6th. That's assistance for just doing the testing. Other than that, they also plan to cover costs for any testing that hasn't been covered elsewhere. One of the things that's really important and was a big point of negotiation was that originally the state wanted the nursing home to bill the commercial insurance company and get a denial before they were paid. Well, they have finally given in to that, and nursing homes are not obligated to pursue commercial insurance in advance, since the state already knows they won't pay. Medicare and Medicaid beneficiaries should be covered, and the labs should be able to bill those entities directly. The department will cover specimen collection costs incurred by the facility, but remember you have to track all of that. And there is a specific tool for tracking all of that information. The state will not cover shipping, but they may consider doing that later. So there's a testing reimbursement form that must be submitted. Reimbursement will be coming through Sigma. So any facilities who are not registered with them must do so. That would be mostly facilities that don't have a relationship with Medicaid. And of course, there's going to be a lot of documentation to keep, including which tests were collected by the nursing homes to ensure that you get all of the reimbursement you need. And that template went out with our member update and is one of the pieces that came through the My Hand notice as well. So we're done. Questions about testing and or any other nursing home related specific issues?
All right. This IDR refers to those F884 citations only for NHSN reporting, correct? Not any COVID-related citation under F884 that you want to IDR.
That's correct.
Okay. If we have a construction worker who might come into the building right now, do they need to have weekly testing? Not our staff or contracted staff like rehab. They are not in resident rooms, but maybe in the SNF area for construction.
My understanding is that you're only required to test persons who routinely visit your facility. If they're not coming on a routine basis, the same person, you don't have to test them. You do have to screen everyone that comes in your facility, and you have to make sure that they're not moving freely through resident areas and things like that. But testing is not required unless they are coming in routinely for a period of time. And there are no parameters that I'm aware of that identifies how often is routine. Well, I think that someone said weekly at one point, but for how long is unclear as well.
Yeah, she said the construction worker may be routine for a few weeks.
I would say more than a month or so, you should probably consider testing.
All right. If an employee had COVID in March and providing weekly plasma, should they be tested?
Yes, they're required to be tested. One of the things that the CDC and other experts are saying that they really do not know how long there is any immunity to the virus. So there might be some limited immunity for a short period of time. It could be a long period of time. Since they're so unsure about that, they want all of the persons tested.
All right. By all costs, is this the weekly test also?
I'm sorry, repeat that, Blake.
By all cost, is this the weekly test also?
I'm not sure. I'm not sure what that question means. If the question is about cost, the state will help with weekly costs for testing. And to be honest with you, I'm not sure what that question is. So if you could give us more information, that'd be helpful.
All right. To bill test collection, is that of any resident tested with specimen collected by us or limited to certain insurance type? Is the $22 the amount that we will receive?
I believe the $22 is the amount that you will receive, and I believe that that is for any test that you collect for COVID related to the testing protocols, which could be for any test, for an admission, for a symptoms, or for ongoing weekly testing. The state's intention is to cover any testing costs for COVID that commercial insurance will not cover and specimen collection. That's my understanding to date.
Is the financial reimbursement form only for testing done through the state's program, or can it be used for testing costs not otherwise reimbursed when done through a private lab?
I believe that you're supposed to record all tests that are not covered by anyone. It isn't just weekly testing.
All right. Can our nurses write the COVID lab order to have staff tested by another entity?
I believe so. The state waiver doesn't confine anyone to facility testing. It simply says that nurses, including LPNs, RNs, advanced practice nurses, and obviously physicians can all order testing.
All right. Is there any data of any person with COVID getting it the second time?
I don't know of any, but I haven't, reviewed all the literature about that. But I have not heard of any, but I think the jury is still out.
All right. Clarification, the state covering the cost for the weekly testing. So I think that was in previous to the question earlier.
Right. My understanding is that the state intention is to cover all costs that are not covered by someone else, no matter what kind of COVID testing it is. We can seek clarification on that, but that was my understanding from many discussions.
All right. If the baseline testing is completed by July 3rd, but we are having difficulty getting everything in order to do weekly testing the week beginning July 5th, will we be cited?
No, you won't be cited as long as you get it done. I believe if I remember correctly, the date is July 17th.
All right. Is that reimbursement form okay for retroactive or from a certain date forward?
I think it's okay for retroactive. I don't remember that question coming up. We will look into that and respond a little bit more clearly in the Q&A.
All right, it looks like that is all the questions. So we would like to say thanks to both Deanna and Dalton for providing all that information and for all the questions that came in today. We would also like to thank our members and participants. I believe we were up near 65 people that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a quick reminder that we will not be having this webinar on Friday. We will be taking Friday off in observance of the 4th of July. So I hope everyone has a great weekend. Just a quick reminder, we do have a Safe and Calm webinar tomorrow at 2 p.m. though. It is separate from this. It's the other series. So we will have that at 2 p.m. So if you're already registered for that, you will get a reminder email, I believe this afternoon, and then 1 hour before it starts tomorrow. Other than that, I don't have anything else to say. So Deanna or Dalton, do you have anything?
No, we just wish everyone a very happy holiday weekend.
Happy Independence Day.
All right. Thank you, everyone, and everyone have a great rest of your day.